Thank you so much for inviting me to be part of the planning committee and to be able to be part of this hero worship group. I love you guys. Thank you so much for being here. Marianne and I are going to divide our time, and hopefully I will be able to swing through some stuff that will entertain and enthusiastically engage you. So why are we talking about this? Well, we want to stack the blocks the right way. If you use a child metaphor, playing with blocks, if we stack them at the beginning in an early way, in a good way, then we get a better, straighter tower. So my job as a developmental pediatrician is to use those blocks to see how you're thinking. And our job as communities is to use those blocks to use it as a metaphor to make sure that we're approaching children at a really early stage and families at a really early stage so we can help them be the best stack of blocks they can be, creating good foundations. So it's much easier to do this at the get-go, same kind of idea. We really have trouble undoing it when it's already been done, so let's fix it at the beginning. Let's get the right ingredients in place, and let's not try to unbake a cake that's already baked. Although I love the resilience message, and I'm going to talk a little bit about that as well. Really, the idea that you can't unbake this cake is probably not really true. And actually, if you think about it, the cake is really good when you eat it. So I love this slide because glue dries and you can't undry it, but it sticks things together, right? Cakes can't be unbaked, but they get eaten at really fun events. So I don't think we need to think about trauma as an undoable thing. I don't think we need to think about adverse experiences as we need to get them out of us. They're going to be there, so what do we do next with it? That's sort of the way I think about trauma, and not forgetting that it occurs. And so, of course, we're trying to do this. We're trying to balance those two things together instead of just ignore them and only focus on the positive. We want to focus on the fact that the negative brings us some positive too, and stack our blocks in a way that the stressors can be overcome. So earlier is better. All right, so I like to think about what can I do to deal with this. As a pediatrician, as a developmental pediatrician, I don't have a lot of control over this. It's like you said, Dr. Anda, the community is where the control is. So if I think about the fact that, do I have a pointer? Oh yeah, okay. Let me see if I can make this work. Thank you. If I only have control over really these two things, that's only 20% of control over how kids' health is determined. That's not a very good set of odds for me. I would really rather be working in this realm, but that's not what they pay me to do. They pay me to work in this realm. So what can I do in the context of determining someone's health that I'm responsible for, or that I have a responsibility in taking care of? So, and I'm part of this boat thing. I'm part of this quality being everybody's responsibility. And I don't like the fact that, I only have that 10 or 20% in my realm, in my clinic room. I want to make sure that I'm paying attention to the whole story. And I love the fact that we're integrating here to do that, because obviously this doesn't work. We're all in the boat together, and we've got to make sure that we're not just blaming somebody else's sector for this. So I also have, my next slide is a nod to Dr. McAllister, Carolyn, because she brought me into this game at the state level. And I think, this is such a huge problem that if we don't figure out how to deal with it, we're going to be in trouble. And we already know that we're there. But if we think about how big it is to solve, it's really overwhelming. So the joke about how do you eat an elephant, one bite at a time. So I'll figure this clicker out. This is a nod to because she's a veterinarian, and I told her I was going to get an animal slide into our presentation today. So that's how we're going to solve this. So now I'm going to talk about some solutions, and I want to talk again a little bit more about epigenetics, because you talked about it in a lovely way, Dr. Anda, but I have a video that I want to make sure you guys get to see. Ignore the fact that I've got this very complex slide because I'm going to simplify it. So is it nature or nurture? The answer is yes. And then here's a pop quiz. So who knows who this guy is? All right. His name is Willie Sutton. So in medical school, we learn about this bank robber. And we learn about him because he was really famous. So in the era that he was active, he was really, really successful. And so this reporter said, "Mr. Sutton, why do you rob banks?" And his answer was, because that's where the money is, right? So I want to spend my 20% of time being able to address that other 40 to 50 to whatever percentage that is. And so what can I do in my purview as a pediatrician to do that? So let's see. So I know about the serve and return model that Jack Chonkoff has put out there in such a lovely way. And the child development psychologists, the developmental psychologists that are among us know about this really well. I think of child development as the basic science of pediatrics. And so when we embed that understanding in what we're doing, we're going to have to look at pediatrics as a two-generation model intervention, if you will. So I've got to pay attention. Now I've got to get out of my slides for a moment and go and show you this. Here we go. So this is a 2-minute video. How am I doing on time?
Responsive to the emotions and the reactivity and the social interaction.
This is Ed Tronick at Harvard.
The world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age. And she gives a greeting to the baby gives a greeting back to her. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions. They turn away. They feel the stress of it. They actually lose control of their posture because of the stress that they're experiencing. It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
All right. So you get the gist, yeah. Okay. All right. So while I'm here, I'm going to go ahead and do this as well, if I can make it work. So this was
deep in the brain of a newborn backpack.
See this. This is about epigenetics.
Green silence the GR gene. When it's active, the GR gene produces a protein that helps the body relax after a stressful event. The type of care a pup receives from its mother during the first week of life can change the expression of this gene.
Hope I didn't mess that up. Oh dear. so loud. Well, let me show you what's going to happen to your genome when your mom takes good nurturing care of you. So this is, I don't know if it's working, but I'm trying to lick my rat pup. This is my nurturing.
It looks like you had better things to do, since you didn't lick and groom your pup very much. Its GR gene is still inactive. Your pup will have a hard time relaxing after stress. Your pup's GR gene will most likely look like this for the rest of its life. In fact, the amount of nurturing you gave to your pup will have a major impact on its adult personality.
My goal is to show you how the DNA changes as I nurture. So, you know, the idea that it would have given me a better message if I had the technology worked out. I'm sorry that I didn't have that better worked out. But you get the gist, right? And one last thing that I will share with you about epigenetics. So there are some things that do not get under the skin, even though tattoos get under the skin. Whether or not those impact us genetically is probably questionable. So, all right, very good. Okay, your turn. While she's doing that, so the purpose is, you know, what a pediatrician has in their control is the family, right? We're there with the family, and if we're only addressing the child's needs, we're missing the boat. We're missing, you know, we could broaden our impact from that 20% to 60 or more percent, and then wrapping ourselves in all of that community context and making sure that we have the understanding of what is out there and available for families, and also being an active, engaging member of building the community around families is really what a lot of the pediatricians that we've already heard today or that we've seen on the video talk about. And now we're going to talk about a case.
So we know we have a high rate. In fact, I believe we have one of the highest rates in the country, and it is an honor, privilege, and my joy that this meeting is happening with all of you. I'm ready for Oklahoma to be number one. I'm ready to be number one in something other than the sports. I love the sports, but let's be number one in helping families do all the things we're going to learn here. So I'm going to identify something you know already. I take care of sick babies. I take care of sick, premature, or other term babies, and I have since we came here in 1975. That's what I was trained to do, and I love it. But I've missed the boat on helping moms and families in the area of this in adverse events, and so I'm going to talk about a case. But part of it is, you know, on intimate partner violence, or that these things, well, you know, I don't know how to ask. That's someone else's job. That's my colleagues actually tell me that. You know, I'm trying to take care of the baby, not the family. That's social workers, case managers. And there aren't any resources available. And we know that's not true. And we've already heard this in spades. And thank you, Dr. Unda, for being here. This is, and Bob Block and all you champions, because I believe this is going to happen and Oklahoma is going to be addressing this. So I want to tell you about a mom with twins. She had a C-section. The older sibling planned to assist and come and help her. This is someone from this region, okay, from all over Oklahoma, but this region. And when her parents, their parents, got involved, the grandparents, who were homeless, her older sister, who lived nearby, said, I'm not taking you and the babies, because she would get the grandparents as well. Now, I knew something was wrong when I went in to see the mom, and the grandparents were sleeping in the one bed in the unit that was for the mom, who had had a C-section, by the way. And I thought, there's something wrong here. So I asked people to talk, etc., and see what we could do. It turns out that these grandparents actually fired every nurse that came in to take care of the babies. There was something they didn't like. I knew that was also something different because I don't usually see that behavior in the grandparents. And then it became very obvious that the grandparents were not a help to this mom. They were homeless, and we had no place for these babies to go home with that mom. So I contacted and made a referral for the children to be placed in custody. Now this was a weekend, and I was out of the airport on Monday morning to fly to one of my meetings in DC, and I called and told my colleagues that they needed to follow up. How popular do you think I was? Not. And I thought, well, so here's what I said: you save these twins' lives. You save these twins' lives. And I believe that. So then I went, well, what can I do next? So this is the next case, and then after these two cases, we'll talk about a few other things. This mother was a prima gravida. I met her the day, because these babies get transferred, and on Monday I come on. I met her the day that she found out the baby was positive for methamphetamine. She was quite upset. And that I was told by the case manager, social workers, that the judge was not going to put the baby in custody of somebody else. So this mom was the baby's only hope. So I walk in and talk to this mom. The father of this infant had another child from a different relationship who had been, child abuse had been filed on the father for abusing this 5-year-old. So, well, this didn't sound like a safe thing to do either. So I contacted the groups that I could, and they just recommended the baby go home with the mom. So I sat and talked with her, and here's what I said. I know you're upset. I want you to know you have a treatable disease. You, the mother, you have an addiction to drugs. You need to go to treatment, get a big book, get a sponsor. Nobody is going to take a postpartum mom in a treatment center if she's immediately postpartum. And you know what? She agreed to do all of that. So the next day I went in, she was feeling better because she'd made some steps in the right direction in her view. And I said, I'm just thinking you had a difficult childhood. Now, I didn't learn those words from Bob Block or Dr. Nanda or any of the people, Dr. Burke Harris or any of those. It just came to me that maybe there was something else going on. And here's what she said. As a matter of fact, I did. Now, I think she trusted me because we'd had this discussion the day before. But quite frankly, that's the first time in my training that I ever had done that. And this was just a couple of years ago. So I'm thinking, well, what can I do to do that? How can I help people? But how can I help her? So I said, you need to do these things, and then you'll be clean and sober and not using drugs, and your baby can go home to you. And then, of course, I finished that week, and off I was to doing something else. She did that. I saw her in the hallway after taking her baby to one of our follow-ups about 6 weeks later. Very fortuitous. The 7th floor is also where some of the clinics are. She looked fabulous. The baby was doing well. And I'm hoping that she still is now about 3 years later. So why has it taken me so long to start looking at how to look at adverse childhood event screening and referral? Is because that's why we're all in this room. We're all in this room because we want this to happen in Oklahoma for every patient, every time that they need it, to get good outcomes. And I'm not going to talk about postpartum depression too much, except to say that we have led the nation in postpartum depression as well. And I will say that the national committee that I was on, appointed through the NIH, now has some information that we can use, because it was an education program, not a research program at the NIH. We have education materials for families whose moms have postpartum depression, but it's very passive, and it sits in the in the books and the shelves up at the NIH, and you have to call and ask for it. So I believe that a lot of our depression is due to adverse events, has already been notified. I'm not going to talk about this because you've heard about this so much, but I do want to end with talking about a component of the pyramid that I believe Oklahoma and Iowa and Kansas have started, the program called Lemonade for Life. How many of you in this room have heard of that? Lemonade for Life. God bless you all. Well, the rest of you need to learn this. So this is a program that the Department of Health, and yes, I'm involved with the Department of Health and the Child Health Education Program, has through a Robert Wood Johnson grant. So it's federal money that's still coming in, despite our budget woes in Oklahoma. And the child home nurse visits that the moms qualify for who get Medicaid. So it doesn't touch the women who have health insurance that also might have those needs, by the way. But so it is through the Child Life home visit program, and those individuals are trained in a comprehensive way to address adverse events during the lives of these moms in particular. It's protected money. I did send an email to the health department saying, do we still have that money? And they said, yes, it's a federal program. So this is important. They're still gathering data and working on it, but this focus is to decrease adverse childhood events and help families. It includes the Cherokee Nation of our 39 sovereign tribes. The Cherokee Nation is involved in this as well. So hopefully it will spread as more money can come. So I'm going to give it back to you, my dear, because that is my vignette about why we need adverse childhood events screening and treatment for everyone every time they need it. Thank you.
So our job as pediatricians is to identify who kids are that are impacted. My take on it is that probably everybody is, or a large percentage of people are. So if you make that assumption and go from there, you might be in better stead. You might be held in better stead. And what can you do now? So screening, find the existing resources in your community. I was presenting this to Stillwater, and I changed that slide, but I forgot to put it back in here. So wherever you live, find your existing resources and embed in those and help them grow. And consider co-location of brain health specialists and pediatricians and family physicians, etc. I think the more power we have to address people when they walk down the hall instead of trying to send them to another organization would be probably more effective. There's evidence that that is more effective. And also, you talked a little bit about this in an indirect way, but the idea that Carol Dweck, who's a psychologist at Stanford, came up with this idea of growth mindsets. So we can help ourselves have one, and we can help our patients have one. So it's that idea that glue sticks you together, or doesn't change after it dries, but it's another way to stick people together. So finding people in your community that want to advocate for themselves and advocate for their children and advocate for the community to be growing and changing. If they've experienced trauma themselves, that's a way to help them have a contribution to improving healthcare services or community services. And, you can either have a fixed mindset, nope, I'm not smart, I'm not athletic, I'm not talented in whatever. Or you can say, you know what, I haven't had enough experience yet learning how to play basketball or learning how to watercolor or whatever it is. And if you think you can, you can. And if you think you can't, you can't. So if you have these changed mindsets, and if you teach people to have those changed mindsets, you can have an impact on this in a way that you have access to somebody right in front of you who you can impact. And if you're thinking about it in this way, instead of I just have to address the baby today, I don't have to address their ecology today, then you can't, you won't. But if you think you can, maybe you can. And there's people out here in this audience that can teach physicians these skills. Here's another example of mindset. and finding out where you are and moving to the next step, eating the elephant one bite at a time instead of trying to eat it all at once. It's less fattening that way. And AAP, this is the last shout out, AAP has a project to enhance child resilience. If you're an AAP member, you can access this website, and if you're not an AAP member, you can access this website. So there's lots of fun resources out there that are all in one place, and there's screening tools and all sorts of useful resources. The AAP is also having a national conference on resilience in March, I believe it's this month. So there's lots of resources for pediatricians. I don't mean to be so pediatrician-centric, but that's who I am, so that's what I know. But I'm really happy to be part of the group here. And thank you so much for inviting me to speak and inviting us to speak.